Sorry, first I must thank you thank you for inviting me. It is my greatest pleasure and to be here. I'm really enjoying the hospitality and very well organized conference and incredibly good lectures. So it is our great pleasure and my great pleasure to be here. What I'm going to talk about, and Dr. Kleiman just mentioned to you that he does all his cases with general anesthesia. So this is what we should do or not, and what are the different ways. So the idea is minimalistic approach or not. So what I put it here is a lot of people describe minimalist. What is a minimalist? So minimalist, they say that pre-procedural minimalist. They say that you don't need a cardiac cath. You can just, no need for CT scan. You can do echocardiogram and measure, or no need for heart team, that you can just have interventional cardiologist see the patient, and that is a real minimalistic approach. Procedurally, you can do it in the cath lab or a hybrid room. You can do it under conscious sedation, general anesthesia. You can use per close, or you can cut down the groin. You can use 1 per close or 2 per closes. You can use a pacing wire, or you can use an LV wire to pace. You can use a transthoracic echo or transesophageal echo. You can use hemodynamics, aortography, none of that to assess the AR. You can use the sentinel device as you saw in the previous talks or not. Or post-procedurally send them to the ICU or send them to the step-down unit or discharge the second day. All of these are reasonable questions. These are all lectures in itself. But what I tried to do is to put in my perspective on it, to say that I think reds are bad, meaning that I think you should not be minimalistic in terms of procedural planning, because this is everything. So you should have all the information about the patient, discuss the patient, be very careful about patient selection. Procedurally, I put green. You can do it in cath lab or hybrid room, and I'll discuss this in a little bit, that what it should look like, what are the goals and benefits. I myself think conscious sedation is the way to go. General anesthesia is overkill. Whether you want to do per close or cut down per close, it should be green, my fault there. Single or double, which side access you like, it's up to you, but I prefer one side access. Pacemaker or wire, you can use either of them. TTE, I don't think TE is necessary. Hemodynamics, crucial. I say sentinel is crucial. ICU stay is unnecessary. And second day discharge is very reasonable. So what is not minimalistic? So this is definitely not minimalistic. This is to, open the chest, do, put them on pump, do a good aortic valve replacement. Is good. I say that is good because it is very reproducible and good aortic valve replacement. And it looks, incision may be small, but this is not definitely a minimalistic approach. So similarly, when you are now looking at our patients, this is a typical slide that we make for all patients. So this is not a slide that I'm making here, but every patient that we do TAVR procedure, this slide is made and it is presented in one of the monitors in the cath lab or in hybrid room. The reason why this slide is made is also tells you that first there is a clinical, on the top it says that which cardiologist and which cardiac surgeon evaluated the patient. I hid it because for the patient confidentiality, but there is a name to the doctors that saw the patient. And then it says that these are the reasons why we are going to do this particular procedure. Then labs are there. Then everybody gets an echo, careful echo assessment. If the gradients are low, the stroke volume index as is reported there, annular area, and it in the parenthesis puts who measured it, so whether I measured it or not, and if I didn't, I'll measure it again. But there is a measurement there and with a name attached. Then left heart cath is done. A good assessment of the angles, coronary heights, whatever, and then what are the real procedural issues are outlined there. We always present it to so no minimalistic approach there. We have a lot of people involved. Everybody is present for every case. So we usually discuss 40 to 60 cases of TAVR per week in one meeting that lasts about 2 hours, and every patient is presented in the meeting. And this is Dr. Swenson, Dr. Turju, Eric, Roselli, myself. These are cardiac surgeons and interventional cardiologists. We work together. And as I say, that is a continuous and open communication, consensus building. We share the resources, we share the credits, and we, of course, have an incredible facility. So this is our hybrid OR, hybrid room. And it is large. You don't need to have such a big room, but we are in Cleveland Clinic, and it is one of the premier organizations. So I built this room, and we just are opening tomorrow or Monday another room like this next to it, which is of stainless steel walls, so it looks even more contemporary. But it is a biplane room. What it has is this is on a floor where there are all the OR. So we have about 15 operating rooms. And for all operating rooms, there is only one pump, which is primed and ready for extra use. So this is a pump that resides in this particular room. So this pump is ready and available. Our goal is that if you have a complication, within 3 to 5 minutes, we said 3 minutes, but maximum 5 minutes, we should be able to provide whatever need be. So is it an open heart surgery, opening the chest, to putting a stent graft, covering the aorta, whatever it has to be done within 3 to 5 minutes. So expertise of the people, nurses, and equipment has to be available, and we practice that. We practice that, meaning we occasionally do a mock run where we say that we have this problem, do we have this coda balloon, we have this stent, we have this thing available in the room or available right there. So all the walls are stocked with appropriate things. But otherwise, in the room, there is not many people. There is anesthesiologist, one cardiologist, cardiac surgeon, and echocardiographic technician. That is all we have in the room. So the resources are limited. No Swan Ganz, no general anesthesia, no arterial line, no Foley catheter, none of that. So these patients come to this hybrid room, looks nice, but they don't get all these kind of crazy things. How do we do these things? So there is an access. So you get a groin access. So you see that there is on the upper corner that we get access in the one groin. After you get an access, you put one per close and an 8 French sheath, and underneath you have another access. So another same needle, I fluoroed it for this slide. I don't fluoro it, just put 2-3 fingers below, stick it. It can be in the common femoral, it can be in the one of the SFA or profunda. So another sheath, and then a sheath for the vein, pacemaker sheath. So there are 3 sheaths placed, and then a sheath in the wrist for the sentinel device. So these are the sheaths that are placed in the single groin, not in 2 groins. This is, again, my way of doing it, but you can do it different ways. And that's why I put it green on the first slide. The sentinel device is placed from the wrist. We use a straight flush catheter, and I'll show you why. 1 per close. Straight flush is to inject dye into the root, and a pacemaker device. And then we connect the pacemaker to the volume line for the anesthesiologist. So in case he wants to give large volume for whatever reason, patient is bleeding. And art line extension in case they want to document their blood pressure. They have an extension from the art line from the same catheter that we put in the aortic root. Straight flush is a catheter very similar to pigtail with multiple holes. Then we place the sentinel device. The sentinel device right there, you can see the sentinel device. It goes on a 014 wire, so you may not be able to see it from a distance, but the wire is in the ascending aorta already. And then you slowly advance the sheath, and there it comes in. And once the device is advanced, this is live, so we didn't do any editing of the film. So here the calcium is seen there, so no need for dye. Most of the time people have calcification, otherwise I put a small catheter in the ascending aorta, so we know where to deploy the proximal filter. So proximal filter is deployed, as you can see there, and once the proximal filter is deployed, the whole film is about 1 minute. So the proximal film is deployed, then we slowly pull that wire, that is the wire, and I pull the wire back, flex the sentinel device, make sure that it does not touch the inner level. So this is the reason this patient is good, because there is some calcification on the inner border of the aorta. And slowly flex the device, and then you find where the carotid would be. So carotid is roughly there. So you flex it a little further and put a small wire like that. The wire goes in, and then you pull back and put the device. So the device, as you can see, is in the left carotid, and this whole procedure takes typically 2 to 3 minutes. This was 1.5 minutes. Once you have done that, this is another very different thing than what you're used to. So a lot of people do it in a coplanar view valve deployment. I don't understand why. So for the biplane, we have a biplane room, but I like to deploy it in a right areocaudal view. So here the valve is placed. The straight flush catheter is in the non-coronary sinus all the way down. It's straight flush, so you don't have to remove the straight flush catheter because it is straight. So it's not a pigtail. And you can see what I've done is I have squared the valve, and the valve is squared in a way that the bottom of the valve is now like a core valve, that you put the core valve, you make the ring, same way. And the line that we are placed is at the level of the annulus. So the white line, the first link of the valve, is at the first line. So you put the valve, bottom of the valve, exactly at the bottom of the annulus. So 0 degrees, 0. And if you look at in the LAO view, so we have biplane room, so LAO, it looks like that. So this is the coplanar view. So if you wanted to look there, it will look like we are going to embolize the valve, but we will not embolize the valve. And we put the valve very comfortably at the 0 annular level. Once we deploy the valve, the next step is to do an echocardiogram. You can click on it, but can you please click on the pictures? But the idea is to check, like Dr. Kleiman was mentioning, that in the cath lab, we check each of the views, make sure there is no aortic regurgitation. If you see aortic regurgitation, and we decrease the aliasing, so very important another thing to keep in mind, echocardiography, the aliasing is 60, you decrease to 39, you see aortic regurgitation. If you start seeing aortic regurgitation, try to correct it. So we will post-dilate it, whatever we have sentinel device, we'll post-dilate. Second thing is to say that hemodynamics. So we are now checking the hemodynamics. So what was before we measure it accurately, that what is the diastolic pressure. There is typically no dicrotic notch when you have severe AS. Second, we have now a dicrotic notch, we have diastolic pressure. So we are looking at 3 things. So this is the same blood pressure before and same blood pressure after. If the dicrotic notch is more than 50% higher, so it's not published yet, it will be published. If it's more than 50% at the higher, it's good news. If the diastolic pressure is equal to the diastolic pressure you started, good news. LV and diastolic pressure in this patient was higher, not good news. But still, and we are pacing. So these patients already started pacing. This is not a good news, even though we deployed it so high. But it goes away. So now we do an aortogram, good aortogram, 20 cc's for 20, 20 for 20. So usually you see well. And here, good aortogram. And good aortogram, if you don't see much AR, then we are at least happy. So all 3 ways we analyze. And then we are not finished yet. Now we take the pacemaker from the ventricle and put it in the atrium and then start pacing. So then we pace it. If we pace it at 120 and there is no vancomycin, 1-to-1 conduction from the pacing, we are very happy. We say patient can go home that day or next day morning. So 80% of our patients go home the next day. We don't have to check anything else because we have a positive, negative predictor. Again, this paper is in consideration. It will be published soon. And then, in the meantime, we give protamine. We removed the sheath. We are holding pressure. There is the wire, stiff wire is there. From the bottom wire, we are injecting a little bit of dye. So see the same side sheath. If it's bleeding or something, we can put a balloon in the bottom sheath and inflate it. We don't have to cross, we don't have to do anything. And if it doesn't, then remove the wire. If it's bleeding, we put one angiosyl. So 60% of times, we have to use another angiosyl. 40% of times, no angiosyl. 60% we use angiosyl, but 40% one per close. And now, we remove the wire, hold pressure with the fellow. We started at 8:47 and we finished at 9:15, half an hour. It is a secret because otherwise they won't pay us money. So half an hour, we are done. Next day the guy goes home. So we are now this is in my way minimalistic approach, even though, and look at this, 11 minutes of fluoro time. We looked at the patient for 11 minutes because the only way we look is with X-ray. So we looked at 11 minutes to his heart. And last year, 500 patients, 60% high risk. We are in Cleveland Clinic. We are not doing low risk patients yet because it's not approved yet. 60% high risk, 40% intermediate, 89% conscious sedation, 90%. Mortality 0.2, stroke 0.2, AR more than 2 plus, 0.8%, less than 1%. And this is not me reading, our echocardiographer. They are not my friends. And permanent pacemaker, 5%. 5%. So I can stand up to Dr. Swanson and my surgical colleagues and say that, listen, I'm doing a good job. Don't worry about it. You can still send patients to us. And all their best friends are our patients because they are all getting older, the surgeons. Their friends are getting older. So they are all our patients because they want to have TAVR, not have surgery. Conscious sedation is the way to go. This is 2017, 89%. As I showed you, 2018, 89%. We are not, and another 11% that we are doing general anesthesia are patients alternative access. So these are the alternative access patients that we are doing general anesthesia. We are not using general anesthesia for transfemoral patients, ever. There are a lot of data. Now data are very hard to analyze, but just to say that no randomized data to analyze all these different things that I just mentioned. You can say that either of these approaches are reasonable, and I put some of the ideas there. Conversion to general anesthesia in the world is 6%. We don't have anything like that. 6% people do not convert to general anesthesia. Again, the conclusion is good that it is up to your institution how you handle it. But I myself think that it is a little bit too much. There is a nice 3M study that was published recently, which patients you can discharge. If you're going to read about it, this is reasonable. And the exclusion criteria, they put some exclusion criteria to say that you cannot discharge this patient next day. Again, I'm not very, there's no recipe for this. If you see the patient, you can decide whether they can go home or not. Outcomes in this 3M registry were good, and even if you're low volume, high volume, and medium volume, you did well. So don't be minimalistic in planning the procedure. Minimalistic in terms of general anesthesia, Foley, lines, ICU, in my opinion, is very acceptable. You don't need any of that. Hybrid room versus cath lab is a local decision. If you are not able to tolerate, in TVT registry, 2% mortality, we cannot tolerate 2% mortality. I will have to stop our TAVR program in Cleveland Clinic. So if we are going to go less than 1%, sub less than 1%, I got to have that 1% saved. So this is the reason why we use it in certain kind of infrastructure. Do not compromise the care, and I think learn from others is a minimalistic approach. And thank you for your attention.
I think the figures were very impressive indeed.
Thank you.
Very, very impressive indeed. Dr. Chlorogiannis, a short comment, please.
Congratulations.
Thank you.
Impressive results. The early results. Any late results?
Yes, we have, so our 1-year mortality is about 11%. 2 years, we have in the next presentation, I have some slides we have now 8-year follow-up of some of the patients, and we have about 8 patients, and I'm going to show you that what is the other advantage of putting the valve high is that the durability of the valve is better, believe it or not. So if you're going to put balloon expandable valve that high, you will be a little bit almost like supraannular, so your leaflet thrombosis and durability will be high. So we had, out of 1,200 patients, 8 patients with some valve deterioration, 3 with TAVR valve-in-valve. So we are following every patient long-term, and knock on wood, so far good results. Yes.
Dr. Sparias.
Samir, thank you for sharing your experience with us. Great results. I think we're going to follow you in many of your suggestions. This is what we're texting with Greg here.
No, I think it will be fun because something new to do. because a lot of people are getting bored with the same way of doing TAVR. So this
Definitely. So my guess is that you are only using Edwards valves, correct?
I won't go that far. I would say that we use about, so last year we used 94% Edwards valves, 6% Medtronic valves. This year we are probably 10% Medtronic so far. The reason is very simple for me. So there are, first of all, if there is no easy problem, there is no, the main limitation of Edwards valve, as you know, is the patient prosthesis mismatch in people with a valve-in-valve small annulus. So if you are going to have such a patient, then we use Medtronic valve. I am less impressed by the AR because we cannot tolerate aortic regurgitation. So even 3–4% of aortic regurgitation was hurting us. So I didn't show you the data for the last 5 years, but in our hands, which may not be the best and it may not be the right in terms of Evolute Pro was not available. So there are a lot of new things that have happened, but this is the reason. And the second is pacemaker. So we are 5%. So we don't have a problem to solve. So that's why we are not using it. And second is that financial thing is that if you use more than certain amount of valve from one company, we get a little bit more discount. And this is, believe it or not, is important. One of the reasons to use one per close, not use a Safari wire and use just a M-Plus accessory wire, less people, is to cut cost. So this is an important part of our.
My guess was based on that you discharged many patients on the following day, and I wonder if you were doing that with Evolute valve.
Exactly.
It's more difficult to discharge.
Impossible.
Almost impossible.
Right, and this is another major challenge because we don't have patient beds. We are doing 16 TAVRs a week. So where are we going to put them?
And my question is, if I heard correctly, you are using protamine to reverse heparin at the end of the procedure?
Everybody, yes.
Right. Because it came across to me, I read it somewhere, that usage of protamine at the end of the procedure to reverse heparin is connected with some leaflet thrombosis, early leaflet thrombosis. I don't know if you're
I have seen that paper and we talked about it, but I don't think that, at least we have not seen any problem with it. And all our surgical patients with bioprosthetic valve, as you know, receive protamine, and we have not seen that problem. So unnecessarily keeping heparin, holding pressures, bleeding and all that is not worth it. So that's why we give protamine.
Are you minimalist or maximalist in antibiotic administration?
In my personal opinion, I'm on a minimalistic side. People would say that, say for Gandhi, Tata, one of our big industrialists from India, said that it is very expensive to keep you simple. So even though I'm a minimalist, it is expensive to keep us minimalist in the sense that we have a lot of infrastructure so that we can practice minimalistic approach. But you are right that sometimes it's harder to be a minimalist than a maximalist.